Let's go through the 4 H's and 4 T's, shockable and non-shockable rhythms in a cardiac arrest in 3 minutes. There are 4 cardiac arrest rhythms which you'll probably come across: ventricular tachycardia, ventricular fibrillation, pulseless electrical activity, asystole. You'll probably hear someone say, is it a shockable rhythm? So let's get into what that means. Ventricular tachycardia and ventricular fibrillation are your 2 shockable rhythms. In ventricular tachycardia, you'll have regular broad complex tachycardia like this on the monitor. It's important to check for the pulse when you see this rhythm because patients can have a pulse and then that'll mean a different treatment line. So make sure you check for that pulse, and this ranges from about 100 to about 300 BPM, which is beats per minute if you don't know. In ventricular fibrillation, the rhythm strip will look much more disorganised like this. You'll have no identifiable QRS complex, and usually this is the precursor to going to regular tachycardia. I've seen it go from this to this so many times in hospital, so just be prepared for that switch up on the monitor. These are your 2 shockable rhythms, and just think V for volt and electricity. Pulseless electrical activity and asystole are your non-shockable rhythms. In pulseless electrical activity, the clue is in the name. You'll have electrical activity but not enough for a pulse in the heart, and it'll look pretty normal on the ECG. So if you see this activity, make sure you check for the pulse. In asystole, there's an absence of electrical activity on the rhythm strip. It's rare to have a completely flat line because you'll have monitoring attached to the patient. So if you see a completely flat line, make sure you check that the monitoring's on the patient properly because you'll get small interferences usually like this. You'll see nurses giving medication, and it's probably 1 in 10,000 adrenaline because that's what we're giving these 2 non-shockable rhythms to begin with. You can give adrenaline in the shockable rhythms too, but you have to have a few unsuccessful cycles first. So just remember that the adrenaline usually is for the pulse's electrical activity and the asystole. Priorities in a cardiac arrest are first identifying the cardiac arrest. In that high quality CPR, identifying the rhythm to make sure if it's shockable or non-shockable, then identify and treat the reversible causes. This is where you're going to come across your 4 H's and your 4 T's. 4 H's: hypoxia, hypo/hyperkalemia, hypo/hyperthermia, and hypovolemia. Hypoxia is inadequate oxygenation, which means homeostasis is unachievable. Hypo/hyperkalemia means your potassium's all out of order and it'll either be really high or really low. Hypo/hyperthermia is an extreme change to your core temperature, and hypovolemia means you'll have a drop in your intravascular volume, so you'll be losing blood or fluid from somewhere. Your 4 T's are your tension pneumothorax, your cardiac tamponade, your thrombosis, and your toxins. Tension pneumothorax is air in the pleural space, which means you have air in between your lung and your chest wall. A cardiac tamponade is blood or fluid around the heart, and we call this the pericardial space. Thrombosis is a blood clot, and this usually causes the cardiac arrest in a myocardial infarction and a pulmonary embolism. And your toxins, so this is a drug overdose or illicit drug use that causes the cardiac arrest, but this one's a lot less common. Hope that helps. I get so many messages about this, so if you're a student and you're watching a cardiac arrest for the first time, you're going to have a bit of a better understanding of what's going on.